Hello, good evening, my dear students. I am Dr. Anshul Devakar, and I am here with you with a very dear friend as well as my own senior mentor, Dr. Gauri Gangakhedkar. Good evening, ma'am.
Good evening, Anshul. It's really weird to be addressed as
No,
ma'am,
but
by you.
but
Very weird.
you are my ma'am. You have been my first teacher
Yeah.
in anesthesia. So today we are here to talk about how to choose a topic for dissertation. This is something that has been asked to me multiple times. And since I am somebody who has done dissertation just once, I can only know my perspective. But Dr. Gori, being now a postgraduate teacher, is a better person to guide you all. So I'm going to just start by introducing her, and so that you all know, you're listening to somebody who is an amazing orator, teacher, and a guide for a lot of students, including me. She is Dr. Gauri Gangakhedkar. She is an assistant professor right now in Tata Memorial Hospital, Mumbai. She is a diploma in and then DNB and then fellowship in neuroanesthesia, and she has certain areas of interest in neuroanesthesia, oncoanesthesia, patient safety. She's also a reviewer for IJA. We all know about it, Indian Journal of Anesthesia, Curious, Clinical Case Reports, Research and Innovation in Anesthesia, Journal of Oncoanesthesia and Perioperative Medicine. And she has been awarded with a lot of honors and publications. She has a Best Paper Awardee at SOPCON 2018, BNA 2019, GSA 2019. She has over 40 publications and, of course, a lot of chapters in the books. But this is just at the surface of what we usually talk about her. At the end of the day, she is just a wonderful, wonderful teacher. She has always been very passionate about anesthesia, and she is one of the first people whom I got scared slash motivated by to read anesthesia. And you all know my first module of resident masterclass was anesthesia machine. My first love of anesthesia machine happened because we met somewhere where she knew everything about machine and I didn't know anything about the machine. So it motivated me to read a lot about it. So today here we are. Welcome, Dr. Gori. It's a pleasure and honor to share a screen with you.
So, like for all of those who are listening or who are ever going to listen to this video, clearly I'm going to record this video for posterity because getting such high praise out of Anshul is just remarkable from my end. I'm sure you've, like from his conversation you've heard, we've known each other for the better part of a decade now.
Yeah.
And the first interaction I think we've had was at R. Yeah, so
Yes.
that was also my first experience, one of my first experiences with Tata, which I eventually fell in love with, and I'm back there forever teaching. But Anshul's a fantastic teacher. We've all heard his modules, and this is my first time doing this for DAM, so I'm very excited about this. He's been too kind about me. There's nothing really, this is just something that's a part of the job, like the CV, everything. I really do like what I do, like he says, but I think that's why we're all here. Like Anshul, we're all passionate about what we do, and that's what makes us click. Otherwise, what are we here for? So I think we can move on to our
We'll
topic
move
of the
on to
day.
the topic that we are here for, and that is the topic we want to discuss today is how to choose a topic for dissertation. This is something a very common and a looming question with our resident who join our department. And they keep asking me, sir, how to choose. And my usual response to them is go ask your guide. And I can only share my perspective because I was being told to just go and meet my guide. And I went to meet my guide, and then she told me, okay, go and find about this and find about that. I was lucky enough to have very good seniors around me who guided me to go and look for journals and then find out articles. So my perspective of choosing a thesis topic is very traditional, that a topic should be what your guide likes, because ultimately at the end of your 2 or 3 years of your residency, it is your guide who is going to come and sign that dissertation. So if she or he likes that topic, he or she has given you that topic, then there are very good chances that, they will sign it very easily and you will move on with your life. So my perspective is very simple. Go eat the head of your guide, try to extract some information, which areas they are interested in, and then try to find out something very simple, something that puts least stress on your brain, something that is doable at your center, something that has lot of cases, something that even your friends can do for you, and something that is existing, that is there. Although the whole point of doing dissertation is to inculcate the habit of research in the student who is later on going to become a postgraduate in anesthesia and practice anesthesia. But for me, it has more practical value of passing the exam, being able to appear for the exam. So I, for one, believe that it is always safer to do something that has already been done. There is a lot of data with it, so that you can play with a lot of things and you know that what you're going through, and suddenly something bizarre doesn't come up and people don't start questioning everything that you have done at the end of 3 years. So my perspective about choosing a topic of dissertation is very superficial. It is also not very conducive with what the board wants you to do. The board actually wants you to inculcate this habit of doing research, because research is everything. If you can find something new, you can try something new, or you can prove that whatever is existing knowledge is correct in your context, then only the field of anesthesia, or for that matter, any branch of medicine, can go forward. But yeah, with this little bit of my perspective, now we are going to actually see how a postgraduate teacher, a standard teacher of anesthesia, thinks about a dissertation, talks about a dissertation, decides about a dissertation. And this is done with this hope that all the students who are listening to it, they put real, genuine efforts in considering this a very important part of their residency, and not just something that helps them to pass the exam or be eligible for the exam. So my perspective is a shallow perspective, which I don't want any of the students to have. But that is the reason why we are here today with Dr. Gori. Now I'll pass on the baton to her so that she can now share her wisdom about this wonderful uh, journey of doing research in your residency. All right, so I'll stop sharing, and yes, over to you, Dr. Gauri.
So, that's what we all love about Anshul, how concisely he's been able to put together my whole lecture in a span of 5 minutes. Most of the stuff that I wanted to already get out to you guys is here. But here we are to talk about how to choose the right thesis topic for you. So I think we all agree that there is no right and wrong thesis topic. A thesis topic must fit you, right? Just as you must fit your own thesis topic. So we'll talk about that in a little bit of detail. So no matter what I say through the course of my lecture, you must remember that the doing your thesis is a part of an intense torture regimen that the MD DNB board set out to you. And that is what it feels like through your entire residency, that I do not know why I'm doing this. And you want to really cry and you want to say, I don't want to do this course. I don't want to do this. And there are points when you hate your guides. But I have a disclaimer for you. I have met some truly, truly wonderful people who've been my guides through my educational curriculum, whether it was my DA, my DNB, or my neuro anesthesia fellowship. And they've truly shaped me into who I am today. And into what I love and how I love it is all because of them. So no matter what I say through the lecture, please remember, I love my guides and they're mentors to me in a very, very true sense. So at the baseline, I must tell you that doing the thesis is compulsory. Whether you do your MD, you do your DNB, you do what you want. Because it is compulsory, you don't have a choice, so you have to do it. Does that mean you have to like it? And I think the answer would be no. You don't have to like it. But you have to do it. It doesn't make you a better anesthetist if your thesis is better, or if your understanding of research is better, right? Your clinical anesthesia is the crux of who you are and how you will approach your patients. Whenever we look at students, we always think when they're passing their exams is this person a safe anesthetist? Is a patient in his care going to survive? Are they going to flourish? If yes, they're good. It's not about what your thesis is or how groundbreaking it is or what results you have found. But if you are going to do a thesis, why not give it your best? Is an outlook that I would like for you to have. If you are anything like me, through MBBS, you've not done a single research, like you've not done any research at all, right? I had not done any research. I had absolutely no idea how to go about this. My first exposure to research per se came with my thesis. And I found that after all the trauma was over, once my thesis had actually been submitted to the DNB, I quite liked the experience of what I had done and what I had found. So I went on with it and I chose to do something academic where I had the alternative of looking for answers. That's not necessarily what you have to do. That may not be the right thing for you, but at least give it your shot. You never know. You may develop a taste for it. What is your usual story when you join MD or DND? Is you go to your guide and then your guide says, you say, sir, ma'am, I'm your student and I've come to you for thesis topic. So you will get these standard set responses. I'm fairly a new teacher like that, but I've been an SR also before. And we have like 30 students a year for MD and TMH. I used to work at KEM before, where also we had 30 students each. So you get, go search for a few topics that you like, put together a list, and then you come back to me and we'll discuss them together. So this is, I think, one of the most scary responses that you can get from your guide because you don't quite know what they want. You've not really done anesthesia seriously as an intern. These are your first few months in anesthesia. You don't quite know what anesthesia is because, internship in anesthesia is largely math. Like I have signed people's logbooks for not attending, even if they've not attended. So I'm assuming that's the case everywhere. Better still are those guides who say that, this X is my area of interest. Like for instance, if you came to me for a thesis topic or I was told to help somebody, be like, let's look for something on the lines of neuroanesthesia, patient safety, onco anesthesia. So, at least I know what I'm looking for. So then if I know, then my student knows, and then they sort of do better. Even better is go to so-and-so, who's like usually a junior consultant in the department, assistant professor types. They will help you. So that person is also struggling to look for somebody to help them with some topic, which is brilliant. It works for you. Even better are those who say, this is your thesis topic, beta. Ye aap kar lo. And that, I think, is the best model for any MD resident who has or DND resident who has absolutely no idea कि उनको क्या करना है. The first response, which is come back with a list of 5 or 10 topics and then we will discuss them at length, leaves you very confused because, like I said, you don't know anesthesia. You don't know what to look. You don't know where to look for. What is the right answer to give to an individual who holds your fate quite literally for the next 3 years. So this is maybe just a helpline. So what are you expected to do when they say do a thesis or look for a study? You are expected to do clinical research. Now, this clinical research could include observational studies where you simply stand and observe. Like you could say, I'm doing an audit of all the airway practices for thyroid surgeries in my institute. So you are going to sort of look at what sort of tubes do people use. Do they extubate after looking at vocal cords? How many patients is intraoperative neuromonitoring used? How many patients develop vocal cord palsies? For how many patients do you require awake fiber optic? Those sort of things. You could have case control studies or you could have experimental studies. Experimental studies are rarely done as thesis topics because we as teachers or even the institute finds it a little cumbersome to actually design a randomized controlled trial which has laboratory tests and medicines and procedures or even behavioral endpoints, like where I'll explain behavioral endpoints in a minute. But, those sort of things for a postgraduate resident, because, no matter how unreasonable your guides seem, they're all aware of how disoriented a PG resident could be to this whole thesis business. So when I talk about behavioral endpoints, it could be something as simple as, those studies that are there. Do women who undergo cesarean sections feel less anxious if they're listening to music? It's a no-brainer answer if you think about it. Obviously, anybody who's listening to music feels better. But measuring that anxiety and getting a quantifiable result out of it, saying that the woman felt significantly less anxious. And not just this woman, that all of the women I studied felt less anxious because they were listening to classical music or instrumental light music, gives you an idea that this is something that everybody could do and everybody would be less anxious. Right? So those are the behavioral measurable endpoints. Other thing you have to look for is the hierarchy of evidence. Now, this is not very important from a thesis perspective because you're going to go to your guide with a topic, which they're going to tweak to their liking, to the feasibility of the institute, and then they're going to tell you how to go about the study. But you must understand what your study could lead to or what the outcomes of your study are. First, you have to understand that there's primary evidence, primary research and secondary research. When it is primary research, it is these sort of things, these expert opinions, editorials, review articles, or then you could have case series, case reports, or cohort studies. Now, case control, cohort study onwards to RCTs. These are the three things that you will conduct as postgraduate residents. The secondary research, which consists of those systematic reviews, synopses, or evidence-based guidelines, are the things that provide a high level of evidence after analyzing those things given below, right? Those RCTs and cohort studies, which essentially means that these three things given above in the pyramid prove to be a valuable tool in trying to figure out what to do as your thesis topic. So what is the step one in sort of doing the thesis? First, identify a broad area of interest for yourself. I know that sounds very difficult given the fact that you know very little about anesthesia when you set up, like I said, but you still have a basic understanding by the time you're choosing your thesis topic. Most of you are in broad specialty institutes where everything is done. Like for our residents, I'm sure in Tata, where not a lot of regional is done, they don't really understand what it would entail. But you sort of understand, do I like regional better? Do I like pain medicine better? Do I like critical care better? Or maybe I like certain aspects like recovery of the patients better. And you have to understand that anything can be the right topic for you. I'll just give you a small example. Now here I have this syringe of propofol and a vial of propofol. This is something that is there on all of our trolleys. If I look at a simple drug like propofol, even off the top of my hat, I can think of at least 8 ways to utilize it as a thesis topic alone. I can obviously look for pain on injection. So I can look at various ways to prevent this pain. I can look at recovery profiles from anesthesia. So I can sort of see, how much doses what sort of doses need to be used to ensure what sort of recovery, what the POID profiles are, how they work in daycare surgeries. Hemodynamic stability as a part of the use of, say, TIVA or TCI pumps, or simply the use of propofol on induction, how stable the patients are in different patient subsets. Or you could use it in different surgeries in different locations. Like, can I use it for nasal endoscopies? Can I use it for gastroenterological procedures, for maintenance or induction? Is it better in IR as compared to ketamine or as compared to, say, thiopentone? Or can I use it to do MRIs? Can I use it to do CTs? Then on the right side, these are these slightly more, I wouldn't call them advanced topics, but these are slightly different. Like they're a slightly different approach on propofol. Does the use of propofol lead to reduced oncological recurrence? It sounds very fancy, and it is. But whether it's the right thesis topic or not for you remains to be seen. If you're in a center that does maybe 2 MRMs a week, you're going to have to follow these women up for 3 years before you find out whether recurrence happens or not. So accruing the right sample size is going to be an absolute nightmare. You can maybe look at instead the impact on the environment. How do we look at impact on environment? You can look at the plastic wastage when you use TCI pumps, the electricity used, and compare it with inhalation agents and see whether the greenhouse effect on or from caused by the use of isoflurane is worse or sevoflurane is worse, or is the use of propofol was simply because we're discarding so much plastic, right? The syringe is there, those extension tubings are there, and then because one syringe is not enough, there'll be two syringes, and then there will be all of those bottles that need to be discarded. Then you could look at cost effectiveness. And there are these recent papers which I found which talk about the use of propofol to prevent depression, treatment of depression. These are anesthetic drugs being used for so many indications. And this is just one drug, one aspect. So you could stand in your OT and you could look at 100 different things. Like maybe you could look at stuff like OT utilization. How much time are you wasting between two cases? Then you need to remember that your research need not be complicated at all. Like I said, how much time are you wasting between two cases? In a big hospital with say like 5 or 10, even 10 theaters a day, if you find that between two cases you're wasting half an hour each, that's a lot of money wasted by the hospital. These are very real thesis topics that are actually going on in some way or the other. It's certain places that I have either worked in or I'm working in. Like, when do people call for help? And do the outcomes change if help is called for? Such a simple thing, right? It's a very, very simple thing. Do you call for help? Obviously, everybody calls for help when something goes wrong. But do the outcomes change? What has to happen for somebody to call for help? How much drug wastage happens at a major center at the end of the day? Now, if you look at it, they seem like questions that are like so simple, but the answers could actually change the way we function. For instance, imagine if among the drug wastage, I mean, among the remainder of fentanyl, you found that you're wasting some 500-600 micrograms of fentanyl because there are some 30 leftover, 30 mics in each syringe as are leftover all across the hospital. The same could be true about propofol. And these are expensive drugs, right? You could have people who have left the oxygen supply on at the end of the day. And that's also money lost. So that sort of drug wastage could potentially be prevented. And it could be a game changer with regards to your hospital policies. Then you could look at just very simply, if you don't really want to invest so much, you don't want to think so much, you could plan audits. Like, what are the behavior patterns and outcomes of patients who are either, say, frail, who are anemic, or those who are undergoing emergent surgery? You find one patient population, stick to it, and say, I'm going to look at this population, like we spoke with thyroid surgeries, and see them through and find out what stands out or if there are any common factors involved. Okay. Step 2, you find a niche that fits you. Now, when I said that I want to do a thesis about, let's assume for my sake, like I like patient safety issues. I want to do patient safety. I identify this. But what do I want to do in patient safety is the second question that I need to ask myself. So how do I find this niche that fits me? I look at where my interest lies. Like I said, I have already decided I want to do patient safety. Then I look at what the current trends in anesthesia research are like. Now that I've understood, I sort of know what I want to do, then I need to find out if my center has the appropriate resources and means to accomplish what I want to find. Let me elaborate a little bit on this. We know from our textbooks that use of etomidate can suppress the HPA axis. I'm not satisfied with that answer. I want to know, is this real? For how long does this happen? Now, very recently, in absolute reality, somebody told me this patient is coming in shock. May I use etomidate to induce? And then I found myself thinking that if this patient is going to come in shock, now you have to remember that I work in a center where we handle the OTs and we also handle ICUs. So I kept thinking that when a patient comes to me in shock in the ICU, I give them steroids. Because I think that, if the HP axis is suppressed and steroids are not being formed, I'm going to lose vasopressors for a lot longer. So if I give etomidate to these patients who are coming in shock for surgery, is this going to impact their ICU stay? No. But so then I decide, let's assume that I want to research this and I want to see cortisol secretion after etom. I have to have a hospital that can support this. I have to have those many numbers of patients who are coming to me in shock and where I am using etomidate. My hospital has to be able to provide enough money for me to run these cortisol tests of sorts, right? then this cortisol test must happen in my hospital. I shouldn't have to send the sample over to another city, another hospital, because that will add to the costs and that will reduce the feasibility of my topic. Which brings us to a very next point. Does my center have the appropriate mindset for such sort of research? It's it's not necessary that your center be as academically oriented as you are. Like I'm very proud to say I have a lot of residents who are really academically oriented, who ask brilliant and wonderful questions, which make you stand back and think. I love having to say, can I think about this and get back to you? I'll have to read a little more. I have a lot of those students. But then, those sort of students don't necessarily get the sort of hospitals where this questioning would be okay. Like, for instance, if a student wants to study the outcomes of patients who are going complicated perforation peritonitis surgeries and says that I want to go and follow these patients up in my hospital, in the ICU also. The cooperation between the ICU team and the anesthesia team may not be so brilliant that all the outcomes will be recorded well. So you need to find out if this is okay for you. What is the timeline I need to set? This is absolutely important in understanding what the feasibility of a study topic is. Now, you have to remember in your 3-year tenure, you have to submit your thesis approximately 6 months before you give an exam. So now you are at 2.5 months, 2.5 years. Then from what I understand, the NMC guidelines for MD students say 3 months of periphery now. So that's 9 months straight off the bat gone. And in choosing your thesis topic, like understanding who your guide is, settling into anesthesia, then choosing your thesis topic, and then going through ethics, on an average, you waste at least 3 months. So that's 1 year of your entire curriculum, which is gone in not being able to work on your thesis. So you have 24 months as a maximum to get your thesis done, in which you must also finish writing it. So I would recommend that you leave at least 1.5 months to simply write your thesis, because writing your thesis is also something that you're not used to. When you take into account that you have somewhere between a month, year and a half to 2 years to accomplish your thesis, inclusive of recruitment, analysis, and then writing your thesis, you must always take this into account when you choose your topic. Like we spoke about the mastectomy example. So you shouldn't, if your center doesn't really do too many mastectomies, don't choose a topic that has mastectomies. If your center is not really into bariatric surgery, even if bariatric surgery seems like the thing that for you to do at that point, that may not be the best thesis topic for you. Choose a simple thesis topic that you can accomplish in the given time period. And I'm sure if research is what you like and you really like what you're doing, how you're looking for answers, you'll find a setup where this works and you will be able to find the answer to your question in your own. And the last question is, can I publish this? The ones that I've highlighted, I'm going to go over in a little more detail in the coming slides. So looking for current trends in anesthesia, critical care, and pain. So what I think you should do is you should go through these PubMed searches. So go to PubMed and look for international journals, that is high impact factor journals. I've just listed a few of them for you. That's anesthesia, analgesia, nature, BMJ. So by and large, they publish good quality papers, right? You also look at national journals. The IJ, JOACP are excellent examples. Why do we look for national journals as well? We look for national journals because they give you a better idea in terms of national and local uses. Let me give you another example. So I was trying to do this study, or we were rather planning a study on using a cardiac output monitor. All said and done, we're a very poor country with very poor patients. All the studies we seemed to find that were done in the West compared non-invasive cardiac output monitors with invasive cardiac output monitors, where both those sorts of cardiac output monitors were attached on the same patient simultaneously. I'm not sure how many of you are aware of the costs of things like float track and those non-invasive monitors, but we were looking at a cost of 40,000 rupees per patient for this. Now, neither the patients, nor the hospital, nor our ethics committee can sort of bear the brunt for this sort of an expense. And then in the end, you also have to understand, is it feasible? Is it justifiable for me to sort of recreate the study in my environment? And then we decided it is not worth it. We're going to wait for larger studies. And they were doing studies on like 150 patients in each arm. So 300 patients, 40,000 rupees each. And that's a really, really large amount of money. So then we figured, let them do those large volume tests. Whatever they find is better, we can simply use rather than testing it out on our own. So when you look at recent papers, you have to look at papers that have come in the last 5 years, right? Anything older than that is actually old. But when you're looking at papers like anesthesia and anesthesia analgesia, like the Western papers, you can still look at slightly older papers to tweak your methodology. And always remember to fall into the rabbit hole, right? You understand what I mean? You open one paper, you like something about it, look for the paper that's similar to it, slightly different. It'll lead you to another paper. It'll help you tweak your methodology. It'll help you understand your topic a lot better if you simply keep clicking what comes next. Right? Look for novel approaches of something. Look for low-cost interventions and alternatives. We're a developing country. If for any reason you can find out that a low-cost alternative works, that's better, right? That is better for the patients, better for the hospital, better for the country, better for everybody. Then I think you should also look at Cochrane reviews and large meta-analyses. If you see my slide, it says what not to do. I'm saying what not to do because if there is a large meta-analysis which has studied 2,000 studies and has assessed data of 18,000 patients, which says propofol is a better induction agent than thiopental, should you be doing studies that compare propofol and thiopental? Not really a good idea, right? Everybody in the world knows that this is a better idea, right? So this is also called assessing the knowledge gap. When you're doing this whole rabbit hole business where you're looking at one paper, then the other, formulating your ideas, tweaking your ideas, you sort of find out what the world does not know currently about the topic that you're interested in. And then you assess if this knowledge gap is something that you as an individual with your guide are in a place to provide for. Then is my favorite topic, good old gossip. This is healthy, right? Gossip is good. Remember that, particularly when it comes to dissertations. When you choose your research topics, you must talk to somebody. All of your seniors. I'm not talking about just your guide. You need to find out who your guide is also teaching, or your immediate seniors, people who've just done their thesis. What should you ask them? You have to learn from their experiences, right? Whether it's good or bad. When I'm talking about good and bad experiences, please remember I'm not labeling guides as good and bad. I'm talking about the experience itself. Like, for instance, I am privileged to work with some of the best minds there are in anesthesia, I believe. And one of them writes the entire thesis topic for her student on her. Now that's brilliant for her student, right? Very, very low effort for them. But what it also means is that they get very little to do. That there's very little involvement, from the student part in that entire thesis. Others I've had the privilege of knowing and working with do not interfere with the student's topic. So it makes it harder for the students to sort of finish and get on the same page as the rest of their colleagues whose guides are a little more hands-on than they are. So why I want you to gossip is because I want you to find out what sort of a person your guide is. Also, like Anshul said, find out what are the topics that they are interested in. If they are interested in a particular topic, Anshul's raising his hand. Give me 2 minutes and then you can pitch in.
I'll just pitch in and tell you a third type of guide who will not help you, who will not let you do your work, and who will create all sorts of trouble for you in the world.
So I have one more disclaimer. I am not them. Okay. I am not them. I have very happily written my student's thesis also. Not very happily. He got bhatti also for it, like for not writing, but I have written my student's thesis, pitched in when necessary. Yeah. So basically what you need to understand is what your guide likes, what your guide does not like. Because if we have a subject area that we identify with, like for me, it is patient safety, like we spoke about before. I know the knowledge gaps to begin with, and I have already assessed feasibility. So if you're willing to work with me on my area of interest, I can give you pre-made advice on this is the topic range. You choose इसमें तुम्हें क्या करना है, and then you tweak the topic to your perfection. I can help you better with literature search also. I can help you better with patient recruitment and feasibility also. When you talk to your seniors, you also find out these hyper local trends. Like for instance, I have this SR who's recently joined us. And from her, I got to find out something very interesting about one of our local hospitals. For the past year or two, thanks to COVID, they've received lots of video laryngoscopes from the Make in India initiative. So their thesis topics have been comparing one brand of video laryngoscope with the other. Fair enough, like good enough to finish off as a thesis, good enough to evaluate the scopes. But if you know that that is the sort of trend which your hospital has, you can look for the hospital that trends that sort of work. Then you look at your workload, like we discussed before. Then your ethics committee approaches. This is something very important, particularly for DNB institutions. With DNB institutions, a lot of your ethics committees don't have so much work as they do in other larger, public hospitals, which also means that they have a lot of time to spend on your thesis. And they're going to scrutinize each and every detail. So if you talk to your seniors, you know what sort of an ethics committee you have, what they will expect of you, and you will send your proposal to the ethics committee better prepared. Also look at cooperation. Like Kanshul said, you look for a thesis topic that your friends can help you with. But what if your institute is the sorts where, like in Hinduja, we had a system where if Anshul's thesis needed to be done and I was posted in some other theater, I could simply tell my consultant, we're doing Anshul's thesis, and they would do it. But if your system is different, where one consultant will manage a case in a certain way, another consultant will manage it in another way altogether, and they won't like interference, then recruiting such patients might become difficult. If you have two separate teams that are discrete, two different units that don't really function well together. So those sort of things only gossip will give you. So please gossip well in the first few months. Find out what works in your institute and then choose your topic. You have anything else to add, Anshul?
Yeah. Uh, I mean, the 2 points which just need reiteration, like we have been in institute where ethics committee was a big pain. In Hinduja, ethics committee was, I think, the toughest ethics committee in India or something like that. They used to scrutinize even the spelling mistakes that we used to do in the proposal we used to send. And every student used to go at least 2 to 3 times to them and then come back and then do changes. So yes, you have to really look at the local factor in your hospital. How do they approach? Also, there are a lot of DNB institute these days who do not have their per se ethics committee, but they have subletted it to a medical college.
Yeah.
And the problem is that most of the time, medical college ethics committee, they don't really look at DNB students that kindly. So you have to also factor in that thing that they are going to be extra harsh to you. And yes, the second point about like in Hinduja, we had this brilliant system. Everybody used to do everybody's thesis. Like it was a department thing. But we have seen a lot of our colleagues who used to just, even if it is a basic.
I think you've gotten muted. Sorry.
So like a basic topic, like comparing two different local anesthetics for a particular brachial plexus technique. But they used to never get posted in the theater when there was a case. And other people used to refuse using that drug. So it has to be like you have to really think it through before you actually approach even your guide with a topic, because you might get enthusiastic. I want to learn USG guided block. So I'll take a topic of USG guided block. Now it happens like out of 12 theaters, only 2 theaters do blocks. And you are never incidentally posted in that theater when there is a case of that block. So you might actually end up spending your entire 2.5 years of your thesis time not actually doing that thing. And ultimately you will have to resort to other means to get it completed. So yeah.
So obviously, if you're in a big department like mine in TMH, we have a lot of people, lot of equipment, and there is a lot of standardizations that's said. So people who are listening to this from bigger institutes may sort of find this harder to relate. But because I've also been a DNB resident, I've had friends who are working in smaller setups and doing their DNB. I can understand where Anshul's coming through. You have 2 USG machines. They're all busy. Your guide is like, for instance, one of the KEM students, the guide, her guide was a neuroanesthetist, not really posted in ortho. So the girl came to us with an ortho topic. This was when I was doing my neuroanesthesia fellowship. We're not going to be able to do this because she's not going to be able to help you. Even if she says, let's do this, she's going to have to rely on the guide herself is going to have to rely on somebody else to recruit your cases. It always helps to sort of align your focuses together, find something that you can do reasonably, and then decide whatever is your area of interest, you can do it again as a separate project. That there's nobody who's going to stop you from doing that. Then the next step is to mock it up and try it out. When I say mock it up and try it out, this is what I mean. Like, for instance, let's assume you decided, this extubation 100% FiO2 is not good. You'll find a lot of papers that say that there is no need to give 100% FiO2 at extubation. So you decide, I'm going to study whether 100%, 90%, 80% makes any difference on post-op room air saturation. This is where the term effect size comes in. Now, what is effect size? This is a quantitative, measurable difference in outcomes, which means that how large does the number of patients have to be for me to find a significant impact? Meaning, how many patients have to desaturate at FiO2 of 80% for me to say that 80 is not as good as 100? I have not really done the sample size calculation for this, but I can assure you for these three numbers, the effect size is going to be so little, like the actual effect is measurable outcome is going to be so little. You're looking at a sample size of say 400. Now, if you're in one of these really large institutes that does 400 patients, where your post anesthesia care units receive 400 patients in 2 months, well and good, this is good for you. But if you're in a smaller center, this is absolutely unreasonable. So when you look for a thesis question, before you go to your guide, find an online program that gives you a sample size. See if that sample size fits within your plan. If it does not, remember that, there is a saying among statistics. If you torture your data long enough, it will give you exactly what you want. What I mean is change your effect size. So instead of looking at impact of, say, post-operative room air saturation, you could look at lung atelectasis. Maybe the quantifiable outcomes are different. Or you could look at saturation, or you could possibly look at requirement of oxygen in the post-operative period. You could look at post-operative pulmonary complications. You just look at a different aspect and see if your outcome measures change so that the sample size fits in your timeline. All right. Then Anshul wants to say something.
Yeah, so I'll give you a practical hack. You decide the sample size that you want, and then you take few studies that you are comparing, and you take them to the biostatistician, and then you tell them that this is the sample size I want. Now you take which primary intention fits in the sample size, and then I'll make that as my primary goal. That is what I did with my thesis topic.
So you could do that. But what happens, unfortunately, is that if you have an ethics committee like Hinduja or TMH, they're going to study the paper you gave for sample size. And then they're going to tell you that this paper didn't really look at this outcome very seriously. So again, I'm going to stress on looking at your local measures, because this would work in certain circumstances, and I'm all for it. Like I said, you look at the outcome that you want to get the sample size that you want. As long as your basic research question remains the same, you can change your objectives a little bit to ensure that this is a feasible study topic for you. Then you also need, I want you to try it out. For instance, you find out that Loxicard helps you prevent pain on propofol injection. Now, this is a topic that has been done to death. Death meaning every single individual knows this. But you still decide, for whatever reason, or in their wisdom, your guide decides that this is only what we want to do this year. हमें इसके अलावा और कुछ नहीं करना है. So you want to change it a little, no? So you'll say, maybe I can try 1 ml versus 2 ml, or 1 ml versus 4 ml, or whatever your thing is. Try it out in a few patients first, even before you do this. As long as it's not something that has never been done before, it is safe for your patients. Try it out in your OT to see what the practical issues with actually implementing such a thesis would be. Then go and present it to ethics and say, this is what we want to do. Because if you go there and then find out that, this was not really feasible, ethics ne pass kar diya, DNB board ne approve kar liya, but when I started doing the study, ye to nahi ho raha hai, then it's too late because you've lost about a year. Because in that whole timeline that I spoke about, DNB actually makes you submit dissertation title also. You're stuck. If you're doing one of those randomized control trials, you have CTRI also. You have very, very little time. Your time is extremely precious. So don't waste time in things that are not feasible. Now
So,
that my
like,
research question is fixed.
I'll just pitch
Tell
in.
me.
Like, I had this thing when I was doing my thesis. We had this new kid on the blog, the QL thing.
Right.
Gauri knows it very well that I was a victim to QL blog. So we did a pilot sort of a thing. We used QL in post nephrectomy pain patients, and every patient that we used to shift to recovery room used to yell in pain, and then rescue analgesia used to be given. And after 10 cases, we realized, okay, either QL is not good for post nephrectomy, or we are not giving QL properly.
We are
Either
not
of the
good at
things.
QL. Yeah.
So we
So which is
decided
why
this is,
we were
yeah,
extremely smart and said we cannot do QL.
QL.
Now if you tell me QL works, right? We do occasionally do use QLs and they work, but we understand QLs a lot better. And I think when Anshul and me were doing this QL business, we had only one type of QL. Now you have
Yeah,
the
now you
new
have four types
innumerable
of,
types of QL.
yeah, yeah, yeah.
So then
And
we
most
can
importantly, the learning curve. When we did, we just had like
absolutely
3 photographs to look at, and then we had to decide, okay, now this needs to be done. We didn't even know how to hold the probe. So
correct. So
something like that.
those sort of things matter. And if we then you can plan your study better. Now that I have decided what my research question is, I'm going to write clear measurable outcomes. For instance, I decide in my whole behavior, I don't really want to muck around too much. I'm not really somebody with a head for numbers. I'm not with somebody who's going to be able to run from one theater to the other looking for something. I'm going to do an audit or an observational simple study. No two groups, no blinding, no randomization, no nothing. No cooperation from colleagues. I'm going to pick up data from papers and copy it, which is okay. It's an okay attitude to have. Please, I'm not mocking you. I'm telling you that it is okay. Not everybody needs to do groundbreaking research to be good anesthetists. Please remember that. Your patients need to be safe, and that's about it. So I decide that my topic is going to be perioperative behavior and outcomes of polytrauma patients induced for surgery with propofol. This is extremely, insanely vague, right? Too many variables. पेरियोपरेटिव बिहेवियर मतलब क्या? पहले का जीसीएस बाद में का जीसीएस देखना है, रिकवरी देखना है, या कौन सा पॉलीट्रामा का पेशेंट है? पॉलीट्रामा कब हुआ है? अभी हुआ है? 2 years ago हुआ है? What sort of polytrauma? Are you doing fracture surgery with regional blocks, or are you giving them general anesthesia for perforation? That also can be caused as a part of trauma. Are you looking at hemodynamics or PONV or what? Now, given the fact that there are so many variables and there are so many outcome measures, you don't have a clear primary objective. When I don't have a clear primary objective, I don't have a clear sample size. And then the whole thing becomes that your Excel sheet, which is your master chart, once you guys start filling it, you'll realize the more number of variables, the larger your master chart becomes. The larger your master chart is, the bigger the nightmare it is for you to analyze it at the end of the day, because you have to analyze every damn thing that you put on your master chart. And the bigger it is, the less sense it's going to make, because even when I look at this topic right now, I don't know what I'm going to find out of this. I'm going to have some patients who are going for orthosurgery, some patients who are going for neurosurgery, some patients who are going for GI surgery. So what should I say? Use propofol? Don't use propofol. If I have clearer defined objectives, better patient population, at least at the end of my study, I can say propofol is a good drug to use for patients in neurosurgery. Propofol is a horrible drug to use if you have lost 4 liters of blood. At least that way I'm clear, because my objectives are clear, my patient selection is clear. So what is a good research idea? It has to be interesting but simple. Simple to do, simple to understand, simple to implement. It should be measurable and replicable. When I say measurable and replicable, like I said, propofol is a better drug. Better in terms of what? Better in terms of, say, pain, recovery. What are your choices? You choose, sorry, and then you do it. And replicable endpoints. Meaning, if I use propofol to prevent cancer, Anshul should also be able to use propofol to prevent cancer. in the same patients. It should not be that only in my hospital, if I use propofol, it is not happening. I'm going to keep the conditions in such a manner that my patients will all use N95 masks. And then I will say that they will use N95 masks. They are patients who are extremely healthy. I will recruit only 18 to 20-year-old males. Not replicable in other institute because you want to be applicable for the entire population. There should be some novelty to this, right? It should either confirm or refute some other findings, or form an extension of previous finding, or provide new findings. Like the VL scope example I gave you. VL scope A is better than VL scope B, or ideally compare it to a standard. So VL scope A is better than CMAC, VL scope A is equal to CMAC, VL scope A is worse than CMAC. All three outcome measures are okay, but they must provide something at all. It should be feasible. You should have the adequate number of subjects and competency. Like we spoke about the QL blocks and the mastectomy in the past. You should have the time and money to do it, and they should be manageable. You shouldn't have to struggle to finish your thesis. It should be ethical. Now, if we take the same propofol pain on injection example, because I want to assess whether propofol causes pain on injection, I can't give one group no Loxicard and the other group we will give Loxicard and see if they don't have pain. I know that it will cause pain relief. Worst example is I know that use of nitrous will cause nitrous in strabismus surgery. We wouldn't do it, but just as an example, nitrous in strabismus surgeries will lead to horrible PONV in women. So I want to find out if palonosetron is a good solution. So I can't have one group where there are only women undergoing strabismus surgeries with nitrous oxide to see if palonosetron works better in these women. No, so one group doesn't get any antiemetic and the other one gets palonosetron. It's not fair to the group that received nothing. So make sure your study is ethical. It should be relevant. There should be a local or national need for it. It should have either higher applicability that way or publishability. Publishability is not really a word, but you get what I'm saying. So there should be a high possibility that the journal will actually want to publish it. So if I'm writing something, why not? Step 4 is my favorite. Show it to your best critic. Your best critic is again that senior who has done the thesis with your guide. It's another professor altogether who you feel close to, who has no stakes in your thesis, is independent and says, ye bakwas hai. Please remember during your thesis, anybody who tells you that ye bakwas hai is helping you, particularly before you go to your guide, because they are pointing out mistakes that your guide would have likely pointed out. And then, you would have taken 2 steps back to sort of identify it. So find your best critic, go to them with your thesis idea. It could be a faculty, it could be a senior, it could be anybody, and sort of hammer the details out. They'll help you tweak your topic. One of the most important questions, can I publish this? You don't have to publish your thesis. There is no compulsion. But if you've worked so hard on your thesis, why shouldn't you publish it? Publishing it gives you your name in anesthesia records for posterity, just as a proof that you worked on this. If you like publishing, you can take it up later again. If you don't, that could be the end of your publishing career, but your name will still be in that journal for posterity. I think that's worth it. And to be extremely honest, once you've written your entire thesis, your whole write-up is ready. You have like 10,000 words of a thesis written. You have to compress it to 2,500 for the journal. Your tables are ready. Your statistics are ready. There's nothing really holding you back from publishing it, except your thesis has to have something of value for the journal to publish. So when you plan your thesis, you know that it's going to be 2.5 years of work. Plan it in such a manner that your work actually bears fruit and your name gets published. This is the way I look at it. I'm sure there are people who look at it in some other way, and they may not be wrong. But I think if I've worked hard, I want to see my name in print. And that's the least that can happen, because nobody's giving you other rewards for your thesis. Also, I think, this is particularly for my students, if you are listening anywhere, or all of the other students. When your thesis is ready for analysis, present it somewhere. as an opportunity. Use this as an opportunity to present your thesis. Stand up in public and sort of present your data that you have to the world. Again, receive critique, because this means that when you publish it, you've already been through this round of reviewing once, right? You have one topic which you have, which is yours, which nobody can take away from you. Make use of the opportunity. Do everything you can with it, right? When I talk about publications, why I'm harping about it so much is this data which is fairly dismal. We have 703 medical colleges in the country, of which 388 are government medical colleges. A 2016 paper said only 25 of these institutes produced more than 100 papers a year. And this contribution of these 25 institutes, which formed 4% of the total institutes in the country, was 40% of the country's total output. Can you imagine the number of theses that are done and are dumped in the corner of the anesthesia office or people's drawers at the end of the day, and they just don't see light of day? So either we are doing such crappy thesis that doesn't deserve publication, or we're simply not taking the efforts to try and publish it, which means we're wasting 2.5 years per student every year in each faculty. So there was another paper that the same year that said 6 out of 10 Indian medical colleges didn't publish any research in the last 10 years. And these papers were fairly landmark in their own right, because they led NMC to sweep in with norms. And now, for promotion purposes, it's essential to have published papers, which may mean, because of which in the past few years, your guides have also become proactive, and they say, let's look for something that's a little publishable, at least promotion ke liye that's useful. Maybe that may not hold in DNB institutes, but at least in medical colleges, that will hold merit, and maybe we'll have better research coming out. I'm hoping I've been able to solve some of your questions at the end of this. I have a small take on this as the teacher who gives the thesis topic. I'm sure all of you are wondering, and if I was fortunately never in a position where somebody told me, go look for 5 topics, come back and then tell me what you want to do. I was handed a thesis topic on a platter and said, this is what you're going to do and this is what you shall do. But I have done this to people. And I found myself asking, after, I have to admit, this was after Anshul asked me about the talk, I found myself asking, why am I telling these kids to go and look when I know that I'm not going to use most of their ideas? Most of their ideas are going to be absolute junk, not feasible. Junk in the sense that I'm in a cancer institute. You want to do one particular regional block where the patient has to stand, limp, do this, do that. Patient is bichara 30 kg ka patient who's not going to be able to do any of these things. I can't keep the patient awake because the surgery is too morbid, and you want to do awake subclavian perivascular blocks and this and that. But I'm doing this because I want to assess, what sort of an aptitude you have. I want to use this opportunity to figure out what interests you, what excites you. Because if I can find what excites you, use a component of this, merge it with my area of interest, I'll have a student who's dedicated to looking at the data. I have a student who is looking for the answers just as much as I am. I also understand what sort of questions you're asking. Like, one of my students told me that he wanted to do a study. His idea of thesis was to do a study where he looked at frail patients, did prehabilitation for them, took them through oncosurgery, and did outcome measures. Clearly someone who's very gifted, very intelligent, very dedicated. But feasibility in a center like Tata was difficult because he has a very small period of time. But when he tells me this is what he wants to do, I know that he'd be willing for a topic that requires a lot of dedication from his end. So if I tell him that you'll measure pain scores at 4 hours after surgery, 6 hours after surgery, and 8 hours after surgery, I know that he also wants to look for answers just as much as I do. So I'm okay to give him a topic like that. If I find that there's somebody who's saying pain on propofol injection, I know I want to give pain on propofol type of a thesis so that they don't feel the need to fudge their answers. Our thesis gets over on time, and I don't have to invest my faculty. They don't have to invest their faculties in it. We leave, each other at the end of 3 years without a tiff. The other thing I would think is that it also gives me an opportunity to sort of tickle their brain cells a little and to find out which of these students would actually want to do research later. Because I'd obviously, as a teacher, I'd love to collaborate later with people who want to publish, who want to learn, and it gives me an opportunity. So yeah, that's that from me, Anjal. You can take it away.
Yeah, so like amazingly lucid interpretation. I actually expected this from you, and
I'm
I'll
glad
just
I
tell
did
you
that.
to mute your mic for a minute because my sound is coming back in the recording. You know, I tend to speak very loudly. So only few funny things I'm going to add at the end of it. One, to all my students, this is how ideally a thesis topic is being chosen, right? Why I wanted Gauri to come and talk about it is I know how organized she is, and that is exactly what she does with all her students, and I'm sure that is what is done in most of the big institutes in India. But as we know that most of the institutes in India which are not so big, the departments are not so well developed, and the DNB institutes that we are looking at, nobody is going to do this hard work for you. But once you know this ideal process, then you will have to do the part of both the student and the guide. So you need to know this process so that you can then invest some time if you are interested. And if you are not interested, then you know how much effort it takes to make a good thesis topic. So you can probably choose not to do it, but you should know what not to look for. And secondly, a very important thing from my end, and although it might sound little humorous to everyone, but my funda of thesis is for the 3 years of thesis, the one thing that you really need to put out of your body and keep it in a safe somewhere is your self-respect. So make sure that you don't have any shred of self-respect, whether it's you're talking to your seniors or you're talking to your guides or co-guides or even ethics committee people, or later on when you go to your HOD at the end of 3 years and you give them the thesis to sign after your guide has signed the thesis, and she looks at the thesis and tells you, what rubbish is this? Is this what you want me to sign? If I would have known this 3 years back, I would have not taken you in the course itself, and something like that. And you keep wondering, okay, 3 years have gone. Yes, we have all been through that. So yeah, please, Gauri, speak.
So I have to add, so I've worked in large institutes lab, majorly. So this is not something I've seen yet. So whether it was KEM or it is TMH, we have a system where we have a department review board. So if you're in an institute which is amenable to solutions, please recommend this. So before a thesis topic is allotted to a student, we usually have a meeting where everybody sits together and says, okay, this is the topic that is chosen. And we sit there and we tweak it ourselves, where all the faculty sits together and tweaks it. The ethics committee in KEM and the ethics committee in Tata needs a signature for the department review meeting, saying that the department has reviewed this project, seems that it is feasible. So that sort of reduces the chance of you going 3 years later and saying, what? This, this cannot be happening. Also, like a sincere request to you guys, if you guys are doing a thesis, take the efforts of understanding how a thesis is written and write your thesis. I'm meaning as a hack, I know that people write thesis as a profession, that it is available as a solution, but give it a shot. It is not tough. People, and this is also true. This is also something that, that you have to remember, that you may not speak good English, and that's not necessary to write a good thesis. Please remember that your knowledge of English, your ability to write science, does not determine your capability as an anesthetist in any manner at all. Scientific language is always a little simpler than spoken English, does not require as much fluency. There's large amount of copy paste with paraphrasing involved with regards to thesis writing. It is possible, like Anshul says, that you'll get yelled at a little more by your guide saying, "ये क्या लिखा है? ऐसे थोड़ी लिखते हैं." It's fine. That's okay. It doesn't determine who you are, so it should be all right. Those language errors are all right. But since that does not impede you from writing a thesis, or that doesn't even make you a bad investigator, if you think you need to do it, please do it. That's
Yeah,
all for
but
me.
writing a thesis is like a completely different thing. I think we'll probably do it someday later how to write a thesis. But yeah, one thing I'll say that if you write your own thesis, then you will be more confident about it, and there are very less chances that anybody can come and question over it. I wrote my entire thesis by hand because on day one of presenting my thesis, I was being accused of plagiarism. I didn't even know what plagiarism is, but I was being told that I plagiarized. And I felt very bad. So I said, okay, now I am not going to plagiarize even a single word. So I opened up a laptop, 5 articles, 5 textbooks. I read all 5 articles, all 5 textbooks, closed down everything and started writing it. And to my surprise, like it was so easy once you read so much about your topic, then it becomes so easy that you can actually write down even the data points and you remember everything about it. And till date, I can talk anything about supraglottic airway devices without looking at any of the textbooks because
And
it just,
DNB also has a table, like DNB and even MD exams have a table for your thesis.
yes,
If you've written your thesis on your own, that's one less topic for you to worry about for the exam. Because
those
one of
20
the favorite
marks.
things, so I also have the unfortunate or dubious honor of having to sit through a lot of our MD exams, where we sit as timers, people who generally help out. I don't have to take them, but I have to listen. And when you have a student who hasn't understood their own thesis, it's heartbreaking.
Yes.
It's heartbreaking because the examiner also doesn't know what to say. Right? But I'm reading this from your thesis. How do you not know what you did? So it becomes very evident that they didn't really participate. So that's, I think, 20 marks, if I'm not wrong, for the exam
Yeah.
from
For
the thesis.
DNB, there is one head on the Viva that is exclusively for thesis and for
Yeah.
communication skills. So that is a combined thing. And I think a lot of emphasis is on thesis because DNB really is putting out it a lot more than MD. MD,
Yeah.
it's
So
in fact,
if you write your own thesis, that's one table you have to worry less about
yes.
because just 6 months you've submitted the entire thesis. You know your work in and out. So that's one place for you to really, really shine. So if you write your thesis, you're good like that.
So this is what we wanted to talk to you all students. It was an extensive, but it was, Gauri, just, can you just switch off the
Sure.
mic?
Yeah.
Yeah. So it was one of the most extensive yet most informative and precise at the same time. Everything. See, I came with a list of 8 questions that I wanted to ask Dr. Gori during the course of her talk, which I thought my students would want to know. And all 8 of them, and plus, I think 10 more of them she has covered. I have nothing to ask to her. I have only a lot of gratitude and a lot of thanks to give to her. She found this time for my students as well as everybody out there. And she shared her wisdom with us, which is something that we were looking forward to. And after listening to this, I do hope that all of you get a better idea about how to choose a thesis topic. And you can always contact me. You can comment on the video or you can directly contact me on my page. And if you have any doubts, queries regarding anything else that you want to know about, then you are always free to ask us and we will come again with another session based on your queries. We want to give it a complete touch so that nothing gets left behind. This is something that is like kind of my tribute to all my students because I see that there is for some basic things, there's a lot of communication gap. And one of the very keen and important points that Gauri has put out in a very nice, humorous way is the ability to gossip. We were in the times when we did not have YouTube and so much use of social media to understand stuff. But you guys are blessed with that, and yet you guys don't talk to each other. But we used to talk a lot. Like we used to know which consultant to talk to and what to do and what not to do. And I think that is something that you have to inculcate as a habit so that you know the local factors that we have spoken about. So this is what we wanted to do. And I thank Dr. Gori from the bottom of my heart. It was also wonderful to see her after a very long time. We keep in touch via messages, but yes, it was very nice to share a screen. And we will definitely come back again with the second part of it. Now, I think it's on my mind how to write a thesis. Again, she is one of the best people to come up and have a talk with this. So very soon we are going to now again come up with how to write a thesis. We are going to extensively discuss the science behind writing a thesis and not the number of people, the professional services who will come and do it for you for some money, but we will share how to exactly go about and write the thesis. So thank you, Dr. Gauri. Please give some wishes for my students at the end.
Thanks so much, Anshul, for the opportunity. It was super, super fun. Clear hanging out with you is always a lot of fun. And like he said, please keep talking to people. Like, I know, I mean, for some reason, people don't talk so much anymore. I I'm somebody who chats a lot, so it's inherently difficult for me to understand why people won't want to talk. And particularly anesthetists, why aren't you talking? Like, why aren't you talking? What are you doing? But yeah, and it's a remarkable platform for you guys, and you have Anshul available as your mentor. Please always feel free to ask him questions with regards to what you feel is difficult for you. And I'm happy to give Anshul my email ID if you have any follow-up questions with regards to how to sort of approach a thesis, how to find a
Absolutely.
thesis. And yeah, this has been brilliant. Thank you.
Thank
Thanks
you.
so much, Anshul.
Thank you. Thank you. Thank you so much, Gauri. And yes, I'll see you all guys again sometime. Bye bye.